Good morning and welcome to Grand Rounds. This morning we are happy to have Dr. Jennifer Lighting with us. Dr. Lighting is Associate Professor of the Department of Pediatrics at the University of South Florida, Morsani College of Medicine. She's also an attending physician in allergy and immunology in the bone marrow transplant departments at Johns Hopkins All Children's Hospital in St. Petersburg. Dr. Lighting completed her medical degree in residency in pediatrics at the University of South Florida. She completed her fellowship in allergy and immunology at the National Institutes of Health and now serves as the medical director of the multidisciplinary immunology program, the co-director of the conjoint immunology bone marrow transplant clinic at USF, and is the medical director of the SCID newborn screening program at USF. This morning, Dr. Lighting is going to speak to us on clinical manifestations and the precision therapy for treatment of primary immunodysregulatory diseases. Please welcome Dr. Jennifer Lighting.
Can you all hear me? Okay. Okay. Thank you for the warm introduction. Let me find this mouse. And I will just jump in and get started. So we're going to spend a few minutes talking a little bit about this concept of immune dysregulation and then different diseases that have been newly described and how we can really make mechanistic therapeutic decisions on how to treat these patients best. So my disclosures, I am a consultant for Horizon Pharma and CSL Behring, none of which have anything to do with this talk. However, I will be discussing off-label use of some medications, and so I'll let you know when we hit upon that. So the learning objectives are to define the non-infectious manifestations of primary immune dysregulatory diseases and describe novel therapeutic modalities for the treatment of primary immune dysregulatory diseases. So I think the first important thing to go over is this concept of immune dysregulation. And this is kind of a hard concept to think about because all of us learn it differently. And when we first think about immune deficiency, what do those words really mean? It means you're deficient in something, you're lacking something. And so the concept of immune dysregulation is kind of turning that on its side in that it's not lacking of some piece of the immune system, but that the immune system is not doing its job correctly, that it's chaotic or dysregulated. And so if you think about what the immune system is for, what its job is in our body, it's really not just to fight infections. Again, when we all learn about these deficiencies, we learn about susceptibility to infection, but there's a lot more to the story. And so one of the jobs of the immune system is to prevent autoimmunity. The immune system is what's constantly surveilling your cells and making sure they're not autoreactive. And when they occasionally escape, that's when you have autoimmune disease, things like lupus or rheumatoid arthritis. It's also responsible for cancer surveillance. So when you go out into the sun on the beach and you lay out there for 2 hours, your immune system is what's allowing you to not get skin cancer every time you do that. So that's its job for cancer surveillance. And then host microbial interactions. So, our GI tract's a good example, is full of microbial flora, and the immune system is what allows us to not constantly be infected with those organisms. Quality matters a lot more than quantity. So I say this to my patients a lot. You can be deficient in one cell type, but if it's working appropriately, you're a lot better off than if it were not. And then too much of anything is bad. So these are sort of the general concepts for immune dysregulation as we move forward. So now we're going to talk about the rare and the more rare, and how to think about these things a little differently and how to find the needle in the haystack, which is kind of the job of us as pediatricians, but also specifically immunologists when we're thinking about immune deficiency. So I hit on this a little bit, but other problems in immune deficiency outside of an infectious susceptibility. So I made this kind of a Venn diagram because they all overlap, and patients often have multiple comorbidities. And so these things, if we walk through it, are failure to thrive, enteropathy, colitis, often early onset colitis, autoimmunity, and that can be hematologic autoimmunity or organ-specific autoimmunity. And the hematologic disorders that we commonly see, so this is non-malignant hematologic manifestations like autoimmune cytopenias or non-malignant lymphoproliferation, splenomegaly, things like that. We can see atopy in immune deficiency. We see endocrinopathies, so things like early onset diabetes or hypothyroidism, ovarian failure in young women, things like that. And then dysmorphic features, of course, can occur as well. And so patients, this is sort of in addition to infectious susceptibility or in isolation. So there are some immune deficiencies where there isn't much infectious susceptibility, that it's really just dysregulation of the immune system. So primary immune dysregulatory diseases is a new classification of diseases that that our field nationally has been trying to describe and really kind of capture and rein in and put definitions of. And so I've sort of defined it here in this slide. The clinical manifestations that we see of these diseases are often chronic autoimmune cytopenias, the non-malignant lymphoproliferation like we talked about, clonal disorders, so cellular clones that are not malignant, so they haven't yet transformed or had mutations associated with them, early onset colitis, enteropathy, endocrinopathy, and growth failure. So the first primary immune dysregulatory disease that was ever described is autoimmune lymphoproliferative syndrome. And some of you may have seen these diseases. This is known as ALPS. It's actually relatively common among the uncommon. And so ALPS is a disorder of abnormal lymphocyte apoptosis. So the way I usually describe this to families is T cells that won't die. So when every immune cell goes through a life cycle. And, it's born out of the marrow, it goes into the periphery, it does its job, and then it has to die. And so T cells in ALPS just do not apoptose. And so when they do not do that, they hang out in lymph nodes and they eventually become autoreactive. And when that happens, that leads to different autoimmune manifestations. Before a T cell dies, it expresses this double negative phenotype. It's CD4 negative, CD8 negative. And so in ALPS, you will see this really large distribution of double negative T cells. And this can be measured on just normal flow cytometry via any commercial lab. You also see persistent survival of these lymphocytes. Like I said, that leads to autoimmunity. The defects that have been described that cause ALPS are in this death domain pathway, and I'm not going to go much into this, but basically there's mutations in pretty much any of these genes that lead to the inability of the T cell to undergo apoptosis. So the clinical manifestations of ALPS, so most patients present in the first 5 years. They often have chronic, persistent, or recurrent lymphadenopathy. This is a picture of a young girl who had this, and you can see these giant cervical lymph nodes. When you biopsy these lymph nodes, they look like reactive hyperplasia. They're very nonspecific histology. There's hepatomegaly, splenomegaly. There's often cytopenias, Coombs positive hemolytic anemia, and ITP and neutropenia, and then a host of other autoimmune features that have been described in these patients, including vasculitis, urticaria, kidney disease, paniculitis, etc. And so these are just histologic pictures of the reactive lymph nodes and then showing, very large hepato and splenomegaly. So the other thing that these patients are susceptible to is malignancy. And so when you have these T cells just hanging out, not dying, they eventually will become autoreactive or potentially undergo mutation to lead to the development of malignancy. And so these patients are predisposed to Hodgkin's and non-Hodgkin's lymphoma, as well as solid tissue tumors of the thyroid, skin, heart, and lung. So how do we diagnose ALPS? So Dave Tichy, who's at CHOP, actually developed this algorithm that's been validated for the diagnosis of autoimmune lymphoproliferative disease. And this is the criteria. So those that are required include chronic non-malignant lymphoproliferation, elevated peripheral blood negative T cells. So both of these can be, deciphered easily by commercial labs or your physical exam or imaging. The accessory primary include a defective in vitro fast apoptosis or germline mutations in an ALPS causative gene. So this gets a little more sophisticated testing. The secondary accessory markers are biomarkers that have been associated with ALPS, and these include elevated soluble fast ligand, elevated IL-10, elevated plasma vitamin B12. And then there's some histology that can be specific, and then family history. And so in his validation for definitive ALPS, patients both required diagnostic features and then one of the primary accessory. If it's probable ALPS, you needed both required features and one secondary accessory. And that gave you your diagnosis. So how do we treat ALPS? So a variety of different things have been tried or utilized, including mycophenolate mofetil, which is Cellcept, rapamycin, IVIG, and rituximab. I will say the top two tend to be the most effective. Patients have undergone transplantation for ALPS, but not with very good outcomes, and so that has not been considered standard therapy anymore. So building off of this is really sort of the hallmark immune dysregulatory disease that was described more than 10 years ago. And now that area has really just blossomed, and there's over now, I think, 50 or 60 immune dysregulatory diseases that have genetic bases. So building off this, the way we started thinking about this as a group was patients who presented with some of these diseases who then didn't have the disease, right? So an ALPS-like patient who looks for all intents and purposes like they should have ALPS, except they don't. They don't meet all the criteria, or they don't have genetic mutations in any of the genes associated with ALPS. And so that's how this sort of blossomed, and then we led to 10 or 15 more ALPS-like diseases that eventually were diagnosed. So this patient presented to me probably about 3 or 4 years ago as an ALPS-like patient without ALPS, and was referred by hematology. So he's a 5-year-old who presented with a 1-year history of profound thrombocytopenia, so his platelet count was less than 5,000 for over a year. He had antiplatelet antibodies present. He also was Coombs positive and antigranulocyte antibody positive, but he was not anemic or neutropenic at the time. He had pretty large splenomegaly and enlarged axillary and cervical lymphadenopathy that you could see across the room because it was so large. Some mild lymphopenia, I don't remember the exact number, and some mild hypogam. One could argue this is actually normal, an IgG of 500 in a 5-year-old, but it's kind of at the lower end of normal. So this is a case of Ctla-4 haploinsufficiency. So I'll get into how we found this in a minute, but this disease was described in 2015 by the NIH group as an ALPS-like disease. So they had taken patients who looked, like I said, like ALPS, but then found mutations in this particular gene. Ctla-4 deficiency is characterized by really the hallmark feature is non-malignant lymphoproliferation in non-lymphoid organs. They have lymphoproliferation in the lungs, the brain, the GI tract. There also is profound autoimmune cytopenias. There can be some hypogam, some lymphopenia. This clonally expanded gamma delta clones can be present, low circulating mature B cells, and reduced Treg cell expression. And all of these are really variable. So not every patient has each manifestation, and not every patient has profound manifestation of this. So at the same time, and I'll get into the mechanism of Ctla-4 in a minute, at the very same time, patients who looked like they had Ctla-4 deficiency were then sequenced and went whole exome sequencing and found to have genetic defects that have a gene called LRBA. So it's sort of like this domino effect of patients presenting like one disease and then we find the next disease. LRBA deficiency was this, again, patients that looked like Ctla-4. They had a susceptibility to certain infections, autoimmunity, thrombocytopenia, colitis, pneumonitis, and a immune phenotype very similar to Ctla-4 deficiency. The skewing of T cells, hypogam, etc. And it was described initially in 3 consanguineous families in which there was recessive inheritance, although looked a little bit X-linked as well. So why do LRBA and Ctla-4 look the same? So if you actually look at the pathway, Ctla-4, and I have another slide that shows this, so if you're not following just yet, don't worry. Ctla-4 is a gene, a protein that sticks off of T cells when the T cell is stimulated. So if you remember from back in your basic immunology days, an antigen-presenting cell presents an antigen, and that's what's happening here, to the T cell receptor. The T cell starts proliferating and doing its job to kill whatever the antigen is. At the very same time that is happening, the T cell is turning itself off. So you're activating and inhibiting at the same time so that at some point this process can stop and we go back to homeostasis. So Ctla-4 is this inhibitory protein that comes out when the T cell has been stimulated. It doesn't sit there normally. It just comes out upon activation. So when you mutate your inhibitor, you now cannot inhibit your T cells. So they're constantly proliferating. LRBA is a scaffold protein that's important for endosomal degradation and helps with the presentation of Ctla-4 on the surface of the receptor. So they rely on each other. That's why they look the same. So an LRBA deficient patient looks very similar to a Ctla-4 deficient patient. So this is showing what I just explained a little bit more schematically, just showing the Ctla-4 on the surface of the T cell that's binding, causing T cell inhibition at the same time that T cell activation is occurring. But why this becomes important is because now there are drugs on the market that can theoretically be used for these particular diseases. Again, this is our schematic showing the Ctla-4 being mutated. So abatacept, which its trade name is Orencia, is approved for the treatment of arthritis, including juvenile idiopathic arthritis, is a fusion protein in which Ctla-4 is bound to IgG, and so it competitively competes with CD28 to bind CD8086. So it's been very effective in the treatment of arthritis, and when given to patients with Ctla-4 deficiency or LRBA deficiency, you are literally giving them back what they are lacking. So abatacept has been used successfully, obviously, in these diseases. And so showing that here, this is a patient with Ctla-4 deficiency, in which you can see that their anemia was transfusion dependent, and with the addition of abatacept became transfusion independent and treated their anemia. The same thing with thrombocytopenia. When giving the abatacept, the ITP became platelet transfusion independent. The same has been shown in LRBA deficiency. This was in 3 patients who had severe interstitial lung disease, chronic diarrhea, pneumonias, etc. And you can see that in the imaging, the pre and post abatacept for each patient, and improvement in pulmonary function tests when abatacept is given. The other thing that's important to show is the time frame. So this is over a very short time. So most of these patients, if you look at this imaging, I think this was within 6 months of initiating therapy. This is extremely quick resolution of underlying disease when you're giving the appropriate therapy. So I'm moving on from Ctla-4, and now I'm going to enter the world of STAT1. So STAT1 is in this schematic is not meant to really walk through. It's really just intended to show that STAT1 is a gene that was first described for its importance in control of mycobacteria. And this was first recognized probably about 15 years ago as a disease related to patients who were predisposed to non-tuberculous mycobacteria that can then disseminate. And it's important in these particular cells, dendritic cells and phagocytes, in the IL-12 interferon gamma axis pathway, in which interferon gamma is continually being produced in order to control mycobacteria. Now we're going to explain what else it does in addition to that. So STAT1 immune deficiency, before we walk through this piece of the slide, if you look at what STAT1 does, it is a transcription factor that hangs out in the cytoplasm of neutrophils, dendritic cells, etc. When those cells are stimulated via interferon gamma, which is produced from other cells like T cells or natural killer cells, that interferon gamma goes through its receptor. It phosphorylates Janus kinases, which phosphorylates STAT1. STAT1 then binds with itself and goes into the nucleus where it upregulates gamma activating sequences. That's what this GAS stands for. When that happens, you now have production of genes that are specific to making more interferon gamma. So this is a positive feedback loop. You're just making more and more and more and more interferon gamma in order to control the infection that's what stimulated it in the first place. When you take out STAT1, it's not an all or none phenomenon. There's all these variations of that. So the way that the nomenclature that we use to describe this is amorphic, hypomorphic, or hypermorphic mutations. Different mutations lead to the protein doing different things. So amorphic mutations mean that no protein is produced. You've mutated the gene and there's very little, if any, protein produced. Those particular mutations are inherited in an autosomal recessive fashion and lead to patients with severe viral and bacterial infections, and they're usually fatal in the first couple years of life. The viral infections are typically herpes viruses, so HSV, CMV, EBV, that often disseminate. Hypomorphic is kind of like amorphic, it's just a little less bad. So hypomorphic, they're making a little more protein, also inherited in a recessive fashion. There's susceptibility to the same viruses and bacteria, also to non-tuberculous mycobacteria, but patients often live longer. So they may get further into childhood, maybe even adolescence, without necessarily being diagnosed or treated with some curative therapy. And then hypermorphic is kind of its own separate beast. So hypermorphic mutations lead to gain of function of STAT1. So you now lead to hyperphosphorylation of STAT1. It's doing its job too well. It's just constantly cranking out more and more and more and more interferon gamma. These patients inherit these mutations in an autosomal dominant way, and they're predisposed to chronic mucocutaneous candida or other cutaneous fungi. They also have severity to other fungal, dimorphic mold, invasive infections. There's autoimmune disease in about a third of patients and a predisposition to development of CNS vascular lesions. So STAT1 mutations as a cause of CMC was first described in 2011. This is the New England Journal article that showed it as a cause for chronic mucocutaneous candidiasis. Now you have to remember at this time, chronic mucocutaneous candidiasis wasn't that rare. We saw it like not that infrequently in our clinics, and at the time we had really no other disease that explained it other than autoimmune polyglandular syndrome. And so when these patients did not have APS, they clearly had something. We found this was the first real major genetic breakthrough in this particular disease. There was a JX Med paper that followed up shortly thereafter that showed that impaired IL-17 immunity is what leads to the chronic mucocutaneous candidiasis or is the break in host defense. So a patient of mine who presented about 5 years ago. She was one of the first STAT1 patients I diagnosed. So she came to my clinic. These were the bottom of her feet. And then this is her body. I've covered up the private areas, but you can see that she's essentially covered in fungus. If you look at her hand a little more closely, this is her hand. So this is a really large granuloma. We had her admitted, biopsied the lesion, and it grew trichophyton tonsurans, which for those who don't know or are not Dr. Layham in the group, this is a cutaneous fungus that does not belong on any of our bodies. It's found in dirt and plants and has nothing to do with us. And so that's what's happening here. We imaged this and she had no break in the dermis. So there was no involvement of her subcutaneous tissue, and there was no involvement of the bone at all, despite the fact that this had been this long going on. So she's able to control it to a degree just at the surface of the skin, but obviously not much more than that. So she ended up having a STAT1 mutation. And so over the last several years, those of us who see these patients have expanded the gain of function phenotype even farther. So now we're sort of subdividing and subdividing more. And so patients who have this gain of function in STAT1 can have just mucocutaneous candidiasis. Those are relatively rare. You also will fit into one of these other buckets. And so some of those buckets are an IPEX-like phenotype. IPEX disease is early onset autoimmunity and neuropathy. It's an immune deficiency that was characterized about 10 years ago. And so patients may look like IPEX disease. They also may have invasive fungi, or they can have this combined immune deficiency where they have hypogam, lymphopenia, and severe susceptibility to invasive viruses. And this is just a review that kind of went over the difference between gain of function and loss of function of STAT1 in immunity. It's a great review for people who are trying to learn a little bit more about this. So Ampule's group out of Europe was able to look at patients who had CMC alone, which is the blue line, and had other complications like the combined immune deficiency or autoimmunity, and were able to show that the patients who had these comorbidities or other complications had a very reduced life expectancy. We had to start thinking about how we were going to treat these patients a bit better. So that leads me to this story. So this is a young man named Nicholas. He is a patient of mine that I met about around the same time as the other woman, about 5 years ago. And when I met him, he had already been transplanted. So when I met him, he was an 8-year-old boy, and his history was that he had had early onset neuropathy. So he had presented in the first 2 months of life with wasting, was TPN dependent, was hospitalized the majority of the first year of his life, and was unable to tolerate any kind of normal infant nutrition, whether breast milk or formula. He also had diabetes that was diagnosed in the first year of life with autoantibodies against his pancreas. He had hypothyroidism that developed around age 2. And then prior to transplantation, he had a Mycobacterium fortuitum lymphadenitis of his mediastinum. All of that very abnormal, right? I think we all can agree that's not normal. So he had been actually transplanted at age 3 with no genetic diagnosis, with really just an IPEX-like phenotype, and they decided to do this because he was dying, and it was used as a life-saving measure. When I met him, he's now 8, but he is a mixed chimera. So he's got some donor, but some of his own cells, and his graft is kind of slowly fading away. And so we have to decide how we're going to handle this. So when I meet him and I do his immune evaluation, he had hypogam, he had lymphopenia, he was getting chronic pneumonia and chronic sinusitis, and again was small, not growing well, and still had all his other autoimmune problems as well. So I put this together and realized very quickly that he had a STAT1 mutation. And he, in fact, did have a gain-of-function STAT1 mutation that led to this early onset IPEX-like disease. So why he became even more interesting is because he had been transplanted. So this is just backing up. This is the article that came out, I think, around 2013 from the NIH group showing gain-of-function STAT1 mutations as a cause of IPEX-like disease. And so I met him around the same time. We sequenced him, and he, in fact, had a STAT1 mutation as well. So why this became interesting is at the time, there was literally one publication of a patient that had been transplanted for gain-of-function STAT1, and this was a 1-year-old who was treated in Peru and had died shortly after transplantation. Now I have a patient who has the same disease who's living in front of me, and nobody has ever reported this. So I quickly wrote up a case report, which got submitted and was immediately butchered to death by the journal that I submitted it to. So they came back and really wanted a case series, wanted more data, wanted more patients. And so we moved quickly to start developing that. During this time, 2 more patients were published, one out of Turkey and one out of Toronto, who also had STAT1 gain-of-function mutations. This patient in Toronto also had HLH as a presenting symptom. And so both of these patients ended up dying in the midst of transplant. The one in Toronto was treated with myeloablative conditioning, and I cannot remember in Turkey. I want to say it was reduced intensity, but don't quote me on that. Regardless, they both died. So we now again have a patient that is living in front of us, and that is important, right? So we need to sort of get the word out. So myself and others developed a connection and found 15 patients internationally that we then collected over about 2 years, wrote up the results of, analyzed the data, and has been published in the Journal of Allergy and Clinical Immunology in 2017. And what we were able to show is that of the 15 patients who have been transplanted for this disease, the overall survival is 40%, which is relatively terrible. So we know that this is not working for whatever reason. When you look a little more closely at the data, so this is the breakdown of those who underwent transplantation. Of 12 who had primary engraftment, of the 15, 6 of them, so half of them, had secondary graft loss. That's a very high incidence of graft loss, and you can see that if you have graft loss, your likelihood of living is quite low. So I think out of those who had graft loss, only 1 was retransplanted successfully and lived. The other is my patient, who is a mixed chimera, and since then has had almost complete graft loss. So the conclusions of this paper, basically we saw 15 patients that were transplanted. The overall survival was about 40%. The indications were life-saving, and so if these patients had been transplanted for a more elective reason, they likely would have had higher survival. 9 died, and the increased survival was associated with the younger age. That was the only one that was statistically significant, but also the use of non-myeloablative conditioning regimens, and there was some survival advantage to a particular mutation that patients had. So now we have to think about how we're going to deal with these patients if transplant is not really going to work. So my particular patient, again, sort of wrote this story and led this work. So as we started treating him, within a couple years, he started developing the recurrence of his enteropathy that he had as a young child. And again, developed severe wasting, massive diarrhea, was hospitalized, TPN dependent, couldn't take anything by mouth. And so we had discussed retransplanting with the family. They really were not interested in doing that, and so we needed to figure out a better way to treat him. And at the same time this is all occurring, these medications, JAK inhibitors, have come to approval by the FDA for different types of diseases, and we started thinking about using those in these patients. So the two drugs that fall into this class are ruxolitinib, which is FDA approved for the treatment of myelodysplasia and refractory graft versus host disease, and tofacitinib, which is approved for juvenile arthritis. So if you look at what JAK inhibitors do, their mechanism of action is that they block JAK-STAT phosphorylation or JAK-STAT activation. So if you remember from the slide I showed before, you have your interferon that comes in, phosphorylates the Janus kinases and these STAT proteins that then homodimerize and go into the nucleus. So you're now inhibiting the phosphorylation of these proteins and preventing basically the activation of them. This also occurs in STAT3, and I'll show you why that becomes important in a few minutes. If you concentrate on the STAT1, we're basically blocking phosphorylation of the Janus kinases and the STAT proteins. So there's been a few papers that had come out before we started looking at this. This particular patient was treated with ruxolitinib and had complete reversal of alopecia. So he was taking 20 milligrams twice daily, and you can see within 12 weeks he had total hair growth. There was also one patient who had been treated with ruxolitinib who had a STAT1 mutation. This was a 28-year-old who had alopecia, chronic mucocutaneous candidiasis, autoimmune hepatitis, and she was treated with ruxolitinib. You can see the hair growth within 12 weeks, and she had resolution of her oral candida. She also had improvement in her liver function test as well. So we started looking at this a little bit more in vitro. Oh, hold on, I'm going too fast. This was the last report of a patient who was treated with a gain-of-function STAT1 mutation, but they looked at its activity in vitro. And so you can see in patients who received ruxolitinib, which is the blue, or tofacitinib, and this is in cell culture, that the phosphorylation of STAT1 was inhibited or suppressed by the addition of ruxolitinib or tofacitinib in the cell dish. They then gave their patient ruxolitinib, and this was a patient who had profound anemia and thrombocytopenia. They go over all the different therapeutic modalities that were used. So they were transfusion dependent, chronic steroids, received ATG, anakinra, cyclosporin. And when ruxolitinib was initiated, you can see the platelet count go up, the hemoglobin stabilized, there was no more need for transfusions, they were able to wean steroids, etc. So it was very life-saving. So we looked at this a little bit more in vitro, and we also wanted to look at natural killer cell activity because these patients are susceptible to severe viral infections. And as you may know, natural killer cells are the cell that's primarily responsible for providing host defense against these viruses. So why are we seeing disseminated viral infections? We couldn't really explain it at that point. And so we were able to show that patients who had STAT1 mutation, gain-of-function STAT1 mutations, had reduced NK cell cytotoxicity and perforin production that improved with the use of ruxolitinib. So your black is the healthy controls, blue is post-treatment. And then the same was shown for, these are all just lysis assays for specific patients, and we were able to show that post-treatment, which is again the blue, that we had improvement in specific natural killer cell lysis, although be it still not normal. So this was, that did show improvement. So Lisa Forbes at Texas Children's and myself have now collected 6 patients with gain-of-function STAT1 internationally who've been treated with ruxolitinib and gone over the details of these patients. This paper has been provisionally accepted, and so hopefully will come out soon, showing that 2 of these patients have had resolution of enteropathy, 2 had resolution of cytopenias, 3 had control of chronic mucocutaneous candidiasis, and 1 of these patients died. The one that died in this table was patient 4. This is an NIH patient that was one of the earliest patients to be diagnosed and had disseminated coccidiomycosis. Ruxolitinib was started kind of at the sort of end stage, and the patient was sort of already in the process of dying. So we think that had it been started earlier, perhaps we could have had more benefit. And this was my patient, so you can see his stool output. So this particular graph shows up to 4 liters a day. That is a ton of stool. And so he was already starting to decrease a little bit. Interventions at this point were TPN and just bowel rest and things like that. We added ruxolitinib, and within, this is now, if you look at the time, this is days. So in 10 days, we're now down to 500 mLs of stool. And within about 2 weeks after that, he was stooling normally with a normal looking bowel movement every other day. So this, and the preceding time prior to this had been weeks. So this was, pretty quick resolution of this with the introduction of ruxolitinib. So moving on, this is the last one I'm going to talk about. My time. I'm fine. So this is another family that presented to me with another immune dysregulatory disease. So this is an 11-year-old female with autoimmune hepatitis. Her hepatitis was so bad that she was treated with tacrolimus, Selcept, Remicade, rapamycin, rituximab, and Cytoxan, none of which worked. She underwent a cadaveric transplant in 2013. She was about 11, I think she was about 9 years old when that happened, or maybe 10 years old when that happened. When I met her, her new liver was about a year old and was already failing. So she had chronic ascites, portal hypertension, severe electrolyte abnormalities. When I met her, she was intermittently encephalopathic because of hyponatremia. And so in her past medical history, she had celiac disease and ulcerative colitis. She had profound growth failure. And then her immune phenotyping showed some lymphopenia and hypogam. I'll show that in a minute. And some thrombocytopenia. When I meet her, her mother is incredibly small too. And I asked the mom, what's going on with your health and your history? And she says, I've just been small my whole life. There's nothing really wrong with me. And I kind of, she doesn't want to talk about it. And I sort of move on because I got enough to deal with and sort of think we'll get to that later. So we do labs on this patient. She has a bone marrow biopsy, which showed myelodysplasia. And she's intermittently neutropenic and thrombocytopenic during her hospitalization and over the course of 6 months as I treated her as an outpatient. So her immune lab showed an IgG of 497. So this is not bad, but this is getting 3 grams per kilo every 3 weeks of IVIG. That is a ton of IVIG. And the fact that we're only at 497 shows that she's either destroying it or losing it somewhere. So it's primarily in stool losses from diarrhea. She's also very lymphopenic. Her CD4 count's very low and her B cell count's low, but remember she got rituximab, so that's probably more related to the rituximab, although the T cell counts being low are not related to rituximab. She also has a very large population of double negative T cells. So CD4 negative, CD8 negative, 12%. This should be single digits. This should be 2 or 1% of your total population of cells. So this is showing some of her imaging. She had, we had to image her because it was very hard to examine her with the ascites, but she did have pretty bad splenomegaly and hepatomegaly as well. She had multiple liver biopsies looking for evidence of rejection of the liver, and those were always negative, not showing any specific histology consistent with rejection. So her mother finally becomes my patient. Her mother comes to me complaining of fatigue and weight loss, unintentional weight loss. And when I get her history, her mother tells me she had growth failure as a child. She was even on growth hormone. She had enteropathy as a child and colitis as a child, but that's been controlled as an adult. So I examine her, and her spleen is literally in her pelvis. So I go to feel her belly. I feel the tip of her spleen by her pubic bone, and she tells me that. And I ask her if she's noticed this, and she says, "Oh yes, I have, but I didn't think much of it, and never really had it evaluated." She also has pretty large axillary adenopathy. And so when you look at her immune phenotyping, she's hypogam. She had normal titers to everything. She's also lymphopenic without any reason to be lymphopenic. She's not received any medications, and she has an even larger population of double negative T cells than her daughter does. So I sent her to Morphic Cancer Center because I'm really worried about cancer initially, especially with the lymphadenopathy, splenomegaly. And she has this very, very large population of gamma delta T cells that are double negative but are not malignant. They did a PET scan, and you can see that she had some lymph nodes that lit up, and then a gigantic spleen. So this is this family. So this is me. I'm 5'6". I'm not going to tell you my weight. You can guess. Mom in this picture is the middle person. She's 44, and she's about 4.5 feet. And then this is the daughter. And in this picture, she was 13. And I can tell you at the time, my son, who is now 4, I think was 2.5 and was taller than her. So she's the size of about a 3-year-old, essentially. So at the time that all of this was happening, these papers came out back to back in Blood. And this is early onset lymphoproliferation autoimmunity caused by germline STAT3 gain of function mutations. And the same thing, autoimmunity, hypogam, lymphoproliferation, mycobacterium in patients with activating mutations in STAT3. So I immediately started thinking about this in these patients. And if you just look at the characteristics in each of these articles, there's a lot of hematologic cytopenias, some endocrinopathy, a lot of enteropathy, and some other, interstitial lung disease, things like that. There's a lot of, everybody had lymphadenopathy. Most everybody had hepatosplenomegaly, and a large proportion had postnatal short stature. In the laboratory markers for these patients, a lot of them were hypogam. Almost everybody who had been checked had increased double negative T cells, lymphopenia, and then some other things. The Finnish group, so this was the second paper in Blood that was back-to-back, was looking at it from a little bit different perspective, and they had patients that had more infections, but also had some hematologic disease. You can see these patients were getting some infections, one even with mycobacterium, but they had some endocrinopathies, they had some enteropathy, and almost everybody had cytopenias. Interestingly, this particular patient also had LGL leukemia as an adult. That was concerning. And then most of the lymphadenopathy was polyclonal, just like in our patient. So I sent blood to Megan Cooper's lab in Washington University looking for this particular mutation. You couldn't send it commercially at the time. And our family does have a mutation in STAT3. And when they did their in vitro assay looking for gain of function, they showed that the patient had gain of function really worse than any other patient in their series. So our patients in blue are our family, and they both have the same mutation. So the immune phenotype of the gain of function STAT3 is this hypogam, T cell lymphopenia, elevated double negative T cells, and then all this impaired phosphorylation in vitro that you can see. There's also diminished numbers of T regulatory cells that lead to the autoimmunity that's seen. So the reason I show this is because when you guys think about STAT3, those of you who have learned anything about it are probably thinking about Job syndrome. So Job syndrome is the disease that was first described as related or associated with STAT3. And so Job syndrome, also known as autosomal dominant hyper IgE syndrome, also known as loss of function of STAT3, is a multi-system disease characterized by this coarse facies. Many of you have probably seen this set of pictures published by Bodo Grimbacher. Nematoceles related to pneumonia, the retention of primary teeth. This is sort of the medical student pearl that you always see on boards. And then all of these other manifestations. So there's all these non-immunologic manifestations. And then the immune phenotype of hyper IgE syndrome is eczema, very elevated IgE, eosinophilia, etc. So we now have same gene, two totally different diseases based on the functionality of STAT3. The loss of function is this Job syndrome, which I just talked about, and then gain of function is the one that our patient had, which is this ALPS-like disease, IPEX-like disease, with all these different immune manifestations. And so as we looked at this moving forward, we had to figure out how to treat this patient. Because you have to remember, as I diagnosed this, she's literally dying. Her liver is failing, she's encephalopathic, and we have to think of what we're going to do. So when you look at this particular slide and just sort of knowing and reading about STAT1 or STAT3, STAT3 is highly involved in IL-6 signaling, and you have very high elevated levels of IL-6 in the blood in these patients, or I should say you can. You don't always, but you can. And so that's what we thought of in her. And so when you look at IL-6, how can you block it? So there's a host of drugs on the market that are used for to block IL-6. The one that I chose in this patient was tocilizumab, which is an IL-6 receptor blocker. I mostly chose that just because I knew which one it was and how to dose it. I mean, that was honestly how the choice came about. And so we decided to use tocilizumab in this patient, and she is right here. She's patient 2. This is her liver enzymes, and so when you see how high they are, her ALT, AST, this is over 7 days. So this is not 7 months. This is a week of LFTs dropping this quickly. You can see, so she's patient 2. As soon as we saw that this worked, we contacted other groups who had STAT3 patients, encouraged them to use tocilizumab, and we quickly wrote this up as an abstract. that was presented at the Clinical Immunology Society meeting in 2016. So we had 6 patients successfully treated with tocilizumab who had STAT3 mutations. And so the dosing that we used was about 12 per kilo. That's what it's approved for in children for the treatment of arthritis. So it was just being used off-label for its indication. All had resolution of whatever was life-threatening at the time, whether that was lung disease or hepatitis, etc. This is patient 5 who pre-tocilizumab was on 24 hours of BiPAP for interstitial lung disease and within 1 month was down to nasal cannula. So this was wonderful. This was a patient with contractures, and their contractures resolved within a year of starting tocilizumab. So this was all wonderful, except all of our patients started plateauing, and we needed to figure out what we were going to do next. We treated them, we got them under control, they weren't actively dying anymore, but now we had to control their disease a little better. And so at the same time that the STAT1 story was playing out, we decided to use ruxolitinib and gain-of-function STAT3, and this is data that is in the same publication that hopefully will come to fruition soon of 5 patients, the same 5 in the previous table, who were also treated with ruxolitinib. And during that, we now had resolution of a lot of manifestations. So 2 had resolution of enteropathy, 2 had resolution of cytopenias, 2 had resolution of hepatitis, 1 came off of respiratory support, 1 who had HLH had resolution of their HLH, and 3 of 5 ultimately survived. So this is the same tocilizumab chest x-ray. These are just CT scans, and you can see 1 year post-Ruxo. She's on just a tiny bit of nasal cannula in the daytime, and then she uses BiPAP at night. And you can see the improvement in her CT scan. STAT3 has also been transplanted, and this paper is a manuscript in preparation of 13 patients transplanted internationally. It has a bit higher survival than the STAT1 story, but has not been completely worked out, and there was a lot of associations of increased survival being associated with degree of illness, which makes sense, and then death was complicated by a lot of transplant-related complications. So where has this led to nationally? So we've all, started recognizing diseases and figuring out better ways to treat them, but we have to make efforts a little more universal because otherwise we're not going to be able to answer any of these questions. The PIDTC is an NIH multi-institutional organization that's funded by the NIH, and All Children's is a site for them. So it's a multi-institutional study, actually. And so one of the protocols within PIDTC that's now going to be submitted for funding is the prospective evaluation of patients with primary immune regulatory disorders. So I serve as a co-I on this study, along with Troy Torgerson out in Seattle and Maria Grazia Roncarlo, who's at Stanford, with a huge committee, and are trying to then define these diseases. So based on survey data that we've done at centers and just all the publications that we've reviewed, we've developed these manifestations of immune dysregulation and hoping to publish this soon. And I hope that this will then give people a guide of patients that they need to evaluate for these diseases or refer for these diseases, etc. And so the major criteria that we have defined to define immune dysregulation is gut disease, so autoimmune or inflammatory, non-malignant lymphoproliferation in non-lymphoid organs like lung, gut, and brain, immune-mediated cytopenias, lung disease. So let me back up. The immune-mediated cytopenias could be autoantibody-induced or maybe T-cell mediated. The T-cell is usually trial by fire. You sort of just figure it out because of the therapy you're using. The lung disease would be ILD or granulomatous disease. And then all the minor criteria we've listed as early age onset, starting at the top, autoimmune endocrinopathy, autoimmune liver disease, kidney disease, skin disease, joints like arthritis, CNS disease, and we mean this as autoimmune or inflammatory. If you have primary hypogam, so you start out hypogam before any treatment has been given, and that your age of onset is less than 5. So we're hoping, what we haven't sorted out yet is how many you need of each. How many major do you need? How many minor do you need? And I think we'll be able to do that as we prospectively analyze these patients. So these are the genes that we've included in our first aim of the grant. So these are 36 genes that have some impact on Treg effector cell axis. And this was a slide borrowed by from Troy, just showing the different genes we'll be including, and just showing how these genetic diagnoses have really just skyrocketed over the last several years. We also had a survey of all PIDTC centers, so there's 34 in North America, showing how many patients they've transplanted for these genetically defined diseases, and we've captured 170 patients. So if you can see, there's still a very large unknown category. So 54 out of the 170 had no genetically defined disease, and they were transplanted for all of these different clinical manifestations, including lupus, vasculitis, etc. And so part of our grant is going to be to try to genetically define these patients as we prospectively analyze them. We were also able to show, this was sort of my beginnings of a heat map, although it doesn't really look like a heat map, to show the clinical manifestations of these patients. So blue is less than 10%, or I should say less than 25%. Green is 25 to 50%. Yellow is 50 to 75, and red is greater than 75% of patients have that manifestation. And so you can see, respective of genotype, almost everybody had immune deficiency, almost everybody had infections. But then there was a smattering of hematologic cytopenias within certain diseases, lymphoproliferative disease. When it says lung, brain, or endocrine, that means lymphoproliferative disease of the lung or brain, endocrinopathies, etc. And so the manifestations of these patients can be somewhat heterogeneous, but they often overlap. And so that's how we've got to sort that out. So where we're going to move in the future, I think I've proven to you guys that knowing your genetic defect is incredibly powerful information. If you didn't know this, you would have never even thought to use some of these drugs or to interfere with the exact mechanism of what was going on in the defect. Targeted therapies are now available to, quote, fix the molecular defect and allow for clinical improvement. And then we're hoping to open some prospective trials for ruxolitinib. We've been working towards obtaining funding for this so that we can understand the kinetics and the actual dosing of this drug in pediatrics, because right now it's a little bit of just a guessing game. And then I just like to acknowledge all the people who have helped me develop most of this, especially Lisa Forbes at Texas Children's, Troy Torgerson at Seattle Children's, Jen Heimel at CHOP, and many, many others internationally. And I'd be happy to take any questions. Right on time. Anybody have questions?
I'll take one. Mm-hmm. So thank you so much for a great talk. I think from a practical perspective, I'm just going to ask on the hematology side, we often get referrals for cytopenias, either isolated or multiple cytopenias. And it often becomes, what test do I send? When do I send? How do I interpret them? And I know you showed the major and minor criteria, but what is your recommendation on the laboratory side? And then if something comes back red, and it's like, well, when do I get worried? Like, how much? Yeah.
So I think from the hematologic perspective, what I consider chronic cytopenias are either associated with time or poor response to therapy. So if it's more than a year, I think those patients deserve an immune evaluation. If you're not responding to standard therapy, or you're requiring your second, third tier therapies like monoclonal antibody infusions or things more than steroids and IVIG to control the cytopenia, those patients deserve an immune evaluation. Now, does that mean they're all going to have these diseases? Probably not. They at least deserve an immune evaluation. So what does that immune evaluation consist of? My recommendation would be starting with immunoglobulin levels, vaccine titers, so you can really assess their humoral immunity. I would do a lymphocyte subset, and I would look at lymphocyte proliferation. And that's probably where I'd stop. If you're not seeing any abnormalities, so if you're not seeing lymphopenia or hypogam, it's not really necessary, unless you have an extremely high suspicion, it's not really necessary to then go to phenotype them more. You can certainly send extended phenotyping of immune cells. Mayo is where I often send them, and I know you guys have contracts with Mayo, to do extended T-cell phenotyping and B-cell phenotyping that'll break down some of these subsets that are disease-specific a little more closely, but they're very expensive. So I would choose, wisely who you're going to send those to. Otherwise, the hospital's going to start getting mad at you. When they come back abnormal, I think first you need to decide they're abnormal. So there's age-associated norms for all of these. Those are well published. I've done this long enough that I kind of just know them, but if you don't, I'd maybe have like a table or a spreadsheet to compare them to, and then I wouldn't just rely on your reference ranges from the lab, because they're not taking into account the age of the patient. And then if they're abnormal, then you need to work up further. And I think some of that can be sorted out or helped, by us or others who do immunology. The threshold or the trigger of when to send genetic testing is, I think, a moving target, right? So I think if your clinical suspicion is high enough, that they're meeting enough clinical criteria, I would say, who cares what your labs say? Your patient is telling you they have something wrong with them. So at that point, you need to be thinking more of a genetic diagnosis. But if your clinical suspicion is not that high and your laboratory data is more reassuring, then I would say you have time. Hold off and maybe get a little more data, see how it evolves. And that's how I approach it. So I don't send it on everybody. It's a little bit of a feeling. Like you just have to sort of, what your suspicion is for the trigger to send it. So that's how I approach it. But there's no clear-cut guidelines. I think that's what we're hoping to establish moving forward prospectively within this group to help clinicians do it. But it's tough. It's a tough question to answer.
We had a patient in clinic the other day with early onset IBD and a phenotype that was very consistent with IL-10 receptor deficiency. And it turns out that now you can send, in Vita, they run a panel for most autoimmune genes. And if the patient is self-pay, they cap their copay at $250, and they run they run the test. If they're insured, it might be a sliding scale of what they pay, but that they're not going to pay more than $250.
Yeah.
So that for families that can afford that, you might get a relatively quick turnaround.
Yeah, and Vita is really good. I use them a lot. And like Federico said, they have a lot of the genes that are included. The places that you have to there are those outliers of patients who have genetic diseases that didn't get picked up by their genetic screening because it's not perfect, right? It's only sequencing exons. It's not sequencing, splice site or regulatory areas, and so you can theoretically miss things. So I would caution against relying on it too heavily. And then if you look at the data for early onset IBD, the patients there's a group at CHOP who is doing it now where they whole exome everybody, and their hit rate is only about 50%. So I tell patients that when I get the early onset IBD referrals that I'm going to evaluate this, but there's only a 50% chance we're going to even find anything. And so if we find something great, we can deal with it. But if we don't, that doesn't change the fact that they have early onset colitis. You still have to deal with that. It just means that we haven't found whatever it is that we're going to find. I really believe all those patients probably have immune deficiency. We just haven't defined that other 50% yet. So, but Invitae is a good resource, and some of the other labs are starting to get cheaper and cheaper, which is a double-edged sword, So, because patients are going to come in with their genetic report and say, interpret this for me, instead of being utilized as a appropriate diagnostic tool. So, anything else? Well, thank you for your attention.